here by Dr. Christos Bogos. He's the Chief of Neurosurgical Department of the General Hospital Asclepion Volos in Athens. Sorry for my Greek language and pronunciation, Dr. Bogos. Although I am now a citizen of Greece as well, so I have to pronounce those words in a good way. But I'm trying to learn some Greek in the near future. He's the member of the board of Greek Spine Society, visiting professor in the University of Crete, past chief consultant of the National Guard in Dammam, Saudi Arabia. He has a very special interest in a very specific area, which is the transplantation of olfactory and sheathing cells after spinal cord injuries. And although it's not the subject of our talks today, but maybe we can have a total one full webinar on the spinal cord injuries and the different advancements in this regards. The other school is the German school. Although one of them now is not purely representing Germany, he is representing Switzerland now. But they are both graduated and worked in the same school of spine surgery. Dr. Benedict Burkhardt, he has been the chief consultant with Dr. Joachim Ertel in the University Clinic of Saarland for like 10 years, Benedict, right? And then he moved to Switzerland, and he's the successor of Professor Lou, the very famous neurosurgeon in Zurich. And he's recently elected to be the ISMUS president. Congratulations, Benedict, for that. And you really deserve it. And we all expect a lot from you on this regards. And being the successor of Joachim Ertel himself is something difficult to deal with. But I know you're up to the expectations. The last but not least is Dr. Sebastian Zinger. He's a great friend, great educator. He is the successor of Benedict Burkhardt as a chief consultant with Dr. Joachim Ertel in the University Clinic of Saarland, which is, I think, the biggest neurosurgical department in Germany and one of the biggest in Europe. This department is not only producing top-notch surgeons, but also top-notch educators, because there is a lot of hands-on activities going there with two very important and very prominent courses every year in May and September. Hands-on, one of them, I think, purely spine, which is in May, and the other one is about endoscopy in all different areas of spine, not only spine, but also brain and skull base. And being an orthopedic surgeon, definitely I don't understand anything about endoscopy of the skull base and the brain, but I totally appreciate the astonishment I see every year in September of the neurosurgeons seeing the live surgery and the hands-on education happening there. So that's why this specific school of surgery is very, very important in Europe, because it's very educational, produced a lot of very good fellows and consultants. And I think it's one of the very good ways to produce real safe surgeons, which is, I think, very important. And it's one of the take-home messages that the World Spinal Column Society has tried to introduce in a lot of its activities since we started in 24 years ago. And we are still doing the same for our courses. So we are really connected and deeply connected to all the real schools of surgery that tries to produce safe surgeons. We will now start. I think Ms. Shana Imler and Mr. Imad are with us. We have three interesting cases from three participants. I don't know which case will start. We have an idea about some of them, but the participants, the theme of this discussion will be an open discussion with not only the applicants of the cases, but all of us will discuss those cases and we'll discuss the outcome first of all the diagnosis, the proper diagnosis, and then the management of those cases. They are controversial cases, and that's the best way to gather information and exchange experience for brainstorming of an algorithm for difficult cases. Let's start. I don't know what is going to be case number one. If Ahmed and Shana are with us, can you ask the first participant to begin showing us the first case?
Yes, I know Imad just moved him to co-host, so
yes,
he
Dr.
should be
Ayaz
able to
can
share his
mute
screen.
himself.
Thank you, Ms. Shana Emler and Mr. Imad for all your efforts.
Dr. Ahmad, if you would like to share your screen for your case presentation.
Ahmad, are you with us?
Yes, sir, I'm here, but Dr. Ayaz is going to share.
Hello, can you hear
Yes.
me?
Yes, this is going to be the first case. Can you first tell us a few seconds about yourself?
Okay, I am Dr. Ayaz Ahmed, Assistant Professor Neurosurgery in Peshawar, KPK Khyber Pakhtunkhwa in Pakistan. Today I will present a case, a unique case, a 75-year-old, but there is no option to share the screen. How to share
Dr.
this?
Ayaz, share screen is at the bottom, green button.
Yes, there is you can share your screen through the application, through Zoom itself. And I think the Ahmad gave you the access of sharing screen.
Yes, Dr. Ayaz.
It's open?
Yes, we can see your case now. If you can put it on presentation mode so we can see the slides well, so we can see the image as well.
Okay.
Can you start?
Yes, yes. The screen is visible for all?
Yeah, we can see your presentation. Go ahead.
This 74 years old male patient present to my OPD in wheelchair. He is unable to walk from 4 years. Walk with support and power in hands 3/5 in all myotomes, and unable to flex the arms and unable to make a fist. Numbness in the whole bodies, also complaining the constipations. Sign the power in the upper limb 3/5 in all myotomes of upper extremities despite of the shrugging of the shoulder. Hoffman test was positive bilaterally. Increased tone in the upper limbs and lower limbs, and the hyperreflexia noted. This is the modified Japanese Orthopedic Association score. According to this score, the score was in upper limb is 2, while in the lower extremity motor function is 2. Sensory function is 1, and the bladder function is 3. So the total score of Japanese Orthopedic Association total score it's 8, which include in the grade 2. This is the MR scan of this patient. This is the sagittal cuts. You can see the sagittal cuts. There is a C3 and C4 compression of the card and the C5, C6 level. You can appreciate in this image. I label these images. There is also the card signal changes at the C5, C6 level. And this is the axial view of the same patient. C3, C4 is canal stenosis compressing the spinal cord. And this is also the compression in the C5, C5, C6, and C3, C4 level. So this patient was very reluctant to for surgery. I advised 3 years back for the surgical options, but he refused. After 3 years, he came to me and said that I am willing to for surgery. So I explained the prognosis about his surgical outcome. So these are my questions for the panelist. What will be the best treatment for this patient, and which procedure will be good for this patient, and what will be the prognosis?
Dr. Ahmed, first of all, before going on, you said that this patient came 3 years after he presented you for the first time. So those diagnostic findings that you've showed, the clinical examination, is now or 3 years ago? What's his condition now, and what is the change of the neurological complaint 3 years ago and now?
Okay, 3 years back, his power is muscle wasting was not so prominent, but he came in today he met with this patient, and the power, the hands muscle wasting started. 3 years back, the muscle wasting was not so much prominent, but there is muscle wasting started. I just make a small video for this patient if you see this patient.
Isn't it weird that he's still hyper-reflexic after 3 years of complaint?
Yes, sir. Still,
this is weird.
Yes, sir.
Okay, this is interesting. Okay, so let's stop
do
here
you
and ask the. Do you have anything else to show, or we start talking? You have to start talking with the panelists.
Yes,
so I ask Dr. Burkhardt to start talking to Dr. Yaz.
Yeah. So I have one question. Do you have a flexion extension X-ray of the
no,
cervical
sir.
spine?
There is no available such like X-rays.
Okay. Do you have a new electrophysiological examination 3 years ago and now?
Electrophysiological examination was not so much conclusive at that time. Just showing there is the neuropathy, polyneuropathy, not a specific roots mentioned in the electrodiagnostic study.
Okay. Do you have a detailed documentation on the fine motor skills of this patient 3 years ago and now?
In the 3 years ago, he is making a fist and unable to make a fine movements. But no, he is someone give the food in the mouth. He's unable to take foods properly. So he using with much handicapped and walking with the support. So
okay. So from my perspective, you have the questions what I think about this case. And I think that the patient, due to the long period of his complaints and also deterioration of his symptoms over 3 years, has poor prognosis regarding mobility, and that he may be able to walk without a crutch on his own. So that he has to be aware of. I think that because we see deterioration even after 3 years, we should tell him that with the surgery, you can preserve the function he still has, which means that he has some like function left. And if he wants to keep this function left, especially because he can breathe on his own with these C3, C4, I would recommend for this patient surgery, because if he cannot breathe on his own due to the C3, C4 compression, then it's a life-determining situation. And with
Dr. Benedict, can I ask a question, please? It's the same question that I asked Dr. Iyaz. Isn't it astonishing to stay hyperreflexic with all this? So it's still upper motor neuron lesion. Why?
That's astonishing, but I think it's because there is still deterioration going on. There is still it's not a final state where you have
isn't it expected
patient.
In 3 years to be like a flaccid paralysis more than hyperreflexic? It's now still an upper motor neuron lesion for 3 years. This is really astonishing.
Yeah, it is. It is. But if we do not have any other diagnostics available, either we can like initiate further diagnostics, like the electrophysiological examination or another MRI, or we can have this patient consult a neurologist. But I think that when we see what he had 3 years ago and what he has now, I personally think, even though it's not textbook-like, it's related to his cervical spine.
Yeah.
Because
what do you think,
I don't think that the thoracic spine is involved because of the hands. And I would be rather surprised if this patient had a cranial problem, which is it's a slow-growing tumor.
So before going to management, can we ask Dr. Zinger and Dr. Gogos the same question? Why do you think this patient is still hyperreflexic after suffering a severe cord compression and weakness for 3 years? Dr. Zinger.
Maybe it's a kind of stable disease over the 3 years, so there was no much more degeneration ongoing, but of course he only needs little events like a trauma, small trauma that get worse. So
yeah. Dr. Gogos. Dr. Gogos, are you following us? Dr. Gogos? Can you be sure, Ahmed, that he's unmuted, please? Dr. Gogos?
Now I'm on mute. Yes.
Okay. No. You are unmuted. Oh yeah, I can hear you now. So, we were asking about why do you think this patient is still hyperreflexic after suffering cord compression for 3 years?
I heard everything. First of all, I want to thank you for the invitation, and I want to make two questions: Babinski, Hoffman, and ventral reflections, if he has or not.
Dr. Iyaz?
Yes, sir. The Babinski was positive upgoing. In 3 years back, the Hoffman was so much prominent. But today, when he's coming to my clinic, the Hoffman not that much prominent as I noted in the 3 years back. So this is the little bit difference. Yes.
I want to agree with the previous speakers with me. I totally agree on what they said. And from my side, I want to add that is a clearly cervical lesion. I don't want to see any thoracic or brain more. The 3, 4, and 5, 6, they are clearly doing the damage. Of course, we have to note it to the patient that we don't expect so much. We have to proceed for the surgery with an ACDF procedure. And after that, the rehabilitation will give the results, if he's going to give results, because 74 years old, I think, but he has to do after that. And what to gain, we will see time by time. That's my opinion.
Thank you for this comment. You just said that you would go for the ACDF procedure.
Yes.
Would you do 2-level and skip the intermediate level, or?
Exactly.
And I mean, in the MRI scan, the patient has almost no muscle in the back anymore. There is like atrophy of the muscles from C3 to C6. So would you consider also doing, just because of the age of the patient and his condition? I mean, even if he has, we don't know if he has an instability, we just have the MRI, a decompression from the posterior side.
No, I wouldn't do it. I understand what you asked in the beginning for the plain X-rays, flexion extension. I would like to have them also, but due to the age, due to all these problems that he had in the 3 years that was out of treatment, I would go only for these two levels, escaping the medial one.
Can I have a question also for Dr. Benedict and Dr. Gogos and Dr. Zinger as well? We can see also some posterior compression actually in the two levels. So would you think of 360 fusion, or you do the anterior surgery that we will discuss now, if it is two skip levels or a corpectomy beginning from C4-5 corpectomy, for example. So is it going to be only anterior surgery and wait and see, or 360, because we can see also some posterior compression? What do you think about that?
Well, if the patient has, if the patient has no instability, and because he is in a poor condition, and because C4-5 does not look like fresh to me, actually, I love to do anterior procedures, but I think in this case, because it's a very short and simple and costless procedure, I would go for just a posterior decompression at C3-4, C5-6 posterior, and see how the patient will do after this procedure.
And actually, Benedict, there is something strong which favors this technique, because the lordosis is not lost, or at least it's neutral.
Yeah,
so
it's neutral. I think the
you still have room for posterior decompression.
Yeah, I think there is no kyphosis, no real kyphosis. I think the cord has like chance to slip posteriorly, and I think because of the
you'll do decompression from 3 to 6 and fuse, or just limited decompression on those two levels by endoscopy or something.
If there is no instability, I would not consider fusion. If there would be instability, then I probably
will do limited decompression in the two levels, not full decompression from C3 to C6.
No,
right?
just the two levels. Just the two levels, because C4-5, there is no compression. And I would only do the compression where the compression is at. I would skip C4-5.
Okay, and you will do this by endoscopy?
Because it's bilateral, I don't think that there would be a big benefit. Also, because there is no muscle in the back. If there would be like lots of muscle, you could preserve this, but because there is no muscle, the advantage of endoscopy, and because it's bilateral and it's in two segments,
so limited,
the advantage is lost.
You mean you will do limited decompression or laminectomy just at this level, right?
It depends on, I mean, if he has a nice window, and I did this in a couple of cases, you can just do a resection of the ligamentum flavum and a partial laminotomy, which means that you do not have to do a laminectomy.
Yeah.
And
laminotomy
I would.
So you think that the compression here is coming more from the ligamentum flavum rather than bony?
Yes.
Okay. What do you think, Dr. Gogos and Dr. Zinger, please?
Well, I still favor it on the ACDF procedure. I wouldn't go from the back, due also for the muscle, as we said. And also, by definition, doing laminectomy, you need to stabilize also the patient. So I wouldn't put screws from the back. And also, the compression is more from the first side, from in front of the cervical. And if you don't remove also that disc there, even if the age is too big, he wouldn't gain anything. And all my cases that I had till now, after 35 years of experience, I think that we should go only in the front, do the ACDF, and not from the back.
Okay. Dr. Zinger?
I think you have to be honest with the patient, and you have to discuss the options. And also, it's a question how good your follow-up of these patients is. If they have to travel a lot, that you can screen them afterwards. Maybe it's better to go for fusion. but if you can have a close follow-up of the patient, I would also go with Benedict and only offer the dorsal decomp and increasing kyphosis or any loosening.
Okay, last question for this case, so we can move to the next case because I think all these are possible options. Any chance for laminoplasty for this case? Dr. Zinger? Dr. Zinger, can you hear us?
Okay.
I think there's some disconnection. Dr. Burkhardt?
Yeah, it's reasonable to do that, but then you have to do a 3-level laminoplasty.
Yeah.
I would rather go for 2 levels, only the ligamentum flavum, no laminectomy.
Okay. Dr. Bogus, any chance for laminoplasty for this case?
No.
No. Okay. Dr. Zinger?
Oh, only decompressing.
Oh, you're decompressed. Okay. So I think with no preference, I think there is a chance for posterior and anterior surgery because this case did not lose completely lordosis. And the options, Dr. Iaz, are either going from anterior, 2 separate decompressions and ACDFs. Some would do a corpectomy of the 2 vertebrae, C4, C5, and I think the problem here with this patient and with his age will be with the poor fusion. So this is another option from
two-level
anterior aspect.
corpectomy.
Yeah, very difficult, but it's theoretically speaking, maybe some would prefer to do something like that. From posterior aspect, we have 2 votes here for the possibility of laminoplasty, which is a real possibility from C3 to C6. At least myself and Benedict think that this is possible. Limited decompression from the posterior aspect is really worth it because it's the least invasive. The patient is losing no bridges. You're not burning any bridges. And if he's not getting better, you can still go anterior.
Absolutely.
So I think that's very good, and without putting any implant, without putting any cost. So this is, I think, another very, very good option. All these are options theoretically. So it leaves us with the wise saying of Edward Benzel: do what's familiar and what works well in your hands, so you can get a better benefit for the patient. So I think that's all for this case. Thank you, Dr. Iaz, for the presentation and for the brainstorming. And we will move on to the next presentation. Thank you, Dr. Iaz.
Thank you.
Imad, can you get us the next presenter, please?
So next presenter is not available, but the presentation is
Who's the next presenter?
Sir, we have presentation of Dr. Sandeep, and one presentation is of Dr. Mohammad Mazia.
So who's ready? Who's ready from both of them?
No, sir, both are not available here.
Both are not available. So until they show up, Dr. Zinger, can you show us the case of posterior decompression? You promised us to be ready with the video of this case. Are you sure? Am I right? You're ready with it?
Okay. I will.
Can you let Dr. Zinger share his screen, please?
I will try my best.
There is already co-host.
Actually, I asked Dr. Zinger to present us one case that warranted endoscopic posterior decompression of the cervical spine. These are very, very interesting cases that this great school in the University of Saarland is doing a great job with decompressing a lot of those cases from the posterior aspect. I've seen a lot of those live surgeries. I was fortunate enough to see those live surgeries, both in the era of Dr. Zinger and in the era of Dr. Burkhardt. So I asked Dr. Zinger to show us one of these interesting cases, and we can open the discussion then. Dr. Zinger, we are all yours.
Okay, so I hope you can see the presentation. I'm sorry that I had issues to travel by train, so I'm sorry I'm not in the lounge to have a good Wi-Fi connection. I hope you can all see the presentation, so I have nothing to disclose. This is a case 3 days ago. He was presented from another department, 64-year-old. He had received ACDF C5-6 before, and ongoing cervical brachialgia, whole arm and hand cervical brachialgia, and we see in a CT scan a bony stenosis in C5-6, C6-7. Shoulder peripheral nerve pathologies were excluded, and the conservative treatment failed. So we offered a dorsal decompression due to the foramen stenosis. We decided to do it endoscopically. This is the system. You go in with a tube-based endoscope, 25-degree angle, and that's the setting for cervical spine. So you do this X-ray, Mayfield clamp fixation, parasagittal, paramedian sagittal skin incision about 2 centimeters, dilatation, X-ray reference that you have the tube inserted right, and then proceed. So this is a short video about the first level of decompression. This is a 4 millimeter burr. We identify the lamina, start drilling until we see the ligamentum flavum. You dissect, and then you decompress with the Kerrison punch. And then when you identify the exiting nerve root after exposure of the dura, you proceed with the decompression to the lateral aspect along the neuroforamen. Double check with the nerve hooks if there's still bony compression. You see the nice image and resolution because you're with the endoscope right at the level of the pathology. Further decompression is performed step by step. You see the exiting nerve root. For orientations on the right side, so 3 o'clock is cranial, 9 o'clock is caudal, 12 is medial, 6 o'clock is lateral. Joint without any risk, instability, further decompression, and a constant irrigation. Checking with the nerve hook again, and then proceed. A single level can be done in 30 to 45 minutes. I think it's a straightforward procedure. So there's no further stenosis. We insert some cell foam with glucosteroids. And if there's no strong bleeding, you also don't need to have any drainage left. And then closure of the muscle fascia and closure of the skin. So the post-op CT scan shows nice decompression of the both sides.
What are your absolute indications to do this procedure, Dr. Singer?
If they have if you identify a clear bony stenosis at the level of the neuroforamen, and if you have a clear cervical brachial fixed at C45, 56, it would be a mess to do it from any. So I think that's a viable with a good result in pain relief.
So it's for radiculopathy. It's a treatment for radiculopathy mostly, not for myelopathy, right?
Yeah. So
Okay.
frequent procedures for radio.
I mean, you can decompress with a tube
Yeah.
a myelopathy from posterior, but I think it's just time consuming. The idea of this procedure is that you target a single pointed problem and that you decompress it. So for me, you need no instability, good lordosis, or maybe a fixed neutral position and a clear single radiculopathy on one side, right?
So it should be very target
this can be
Dr.
either
Booker, right?
Yeah, and this can be either caused by a soft disc herniation lateral or by a bony foraminal stenosis. But if you have circumferential stenosis, of course, you can move all your way with the tube from left to right and remove part of the spinous process and the base and the ligamentum flavum. This is all doable, but it's just time consuming. And I think time for a surgery is always an important factor.
Yeah, especially in degenerative cases where the patient is having more comorbidities.
Yeah, and if you have these cases where the ACDF has been done and due to subsidence or because you could not distract the disc space and you have a persistent neuroforaminal stenosis, which can happen, you can, without a doubt, if this is a unilateral problem, remove the whole facet because it's fused in the front anyhow. And also, if you have a problem at the C6, 7, where the patient has a large anatomy and you have problems to enter it from the front, or C7, TH1, and has a radiculopathy, this is also a valid option, right? But you do
Is
not...
it an age limitation?
We are very fortunate to have Dr. Paulo Pereira still with us. What do you think, Paulo?
Thank you. Thank you. But I was just asking this in the chat that at least in my hands, I do with the tubes instead of the EasyGo, but basically it's the same. It's just using an endoscope or a microscope. It's basically the same thing. But for me, laminoforaminal to me works better for when the compression comes from posterior, from facet arthrosis and facet hypertrophy, comparing to uncinate process hypertrophy, because the compression is still there in front of the nerve root. And that, at least I'm not, and for soft discs, of course. But do you have a different opinion on that?
No, I totally agree. If you have a problem that's coming from the front and you have a bony spur from the uncus and you have not done an ACDF, I would go from the front. But if you have if you have just a ring, a bony ring of the discs, which goes from all the way to extraforaminal, and you have a narrow foramen and arthrosis, it also can be done. But if you have a clear compression from the front, which is bony, then from the posterior aspect to decompress it and to remove this bony spur is very, very challenging, because you cannot manipulate the nerve root from top to bottom as shown on social media and all those videos. This is just not the reality.
Yeah.
Dr.
That's
Bogus, what do you think?
Do you consider age limitations for this procedure?
What do you mean about age limitations? I think
could you do this in a 70 years old and the same in the 40 years old?
Oh, yes. We have a series of over 100 patients, and the age spans from the 20s to up to 85, 90. It has been published.
Okay.
So it's the thing is that it's target oriented. If you can reach your target through this very minimally invasive procedure, it's going to be the answer, and especially if it if the surgeon is really familiar with the procedure. Is that a good description, Benedict?
Yeah, I think you should be aware of the anatomy. You don't drill anything if you're not clear where your tube is at. I think skin incision placement, the determination of the skin incision and the skin incision is key. If you're wrong by ½ centimeter, you have a problem. So before you start doing anything, do a lot of X-rays, AP and lateral, and be sure that you are exactly in the right spot. Once you are there, and once your tube, which has to be close to the facet joint, is sitting on top of this, you cannot lose the orientation because the ring is fixed, and just detach the soft tissue and make the two laminar facet pieces visible, and then drill from medial to lateral, cranial to caudal, and then with a gentle punch, decompress it. And then if you have decompressed the nerve root from posterior, all your work in 90% of cases has been done, exception for soft disc herniations. Then go a bit further to the lateral aspect of the dura and try to squeeze out the sequester. But if the sequester is 6 months old, this can be a different game.
Yeah. So it's a very good selection of patients that really are fit for this surgery. Is that right, Dr. Zinger?
I also agree with Dr. Pereira. If the patient would have undergone sufficient decompression from anterior in the surgery before, we wouldn't have to do it from posterior. So it was an insufficient decompression from anterior. That's why he was administered to us. And we talked with him about the options, but I think it was the at least invasive revision surgery, and the patient is doing well, so on. So, but absolutely, if you have
yeah, if you go from the front, if you go from the front, be sure that you have done a good, thorough foraminectomy.
So this is a very minimally invasive procedure, but it is not that forgiving, right?
No, I think patient selection and skin incision determination is key here. If you select the wrong patient, this will not come good.
Yeah. Okay.
But not only with, just a short mark, but not only with this technique. There is an old paper with 980 foraminotomies done open, and they had, if you look for a 10-year span, they had a 20%, almost 20% reoperation rate.
Yeah. Okay. So I think we have to move to the next case. We don't have the applicants of the next two cases with us, so I will try to show you the cases, and we open the discussion. Imad, can you show us the case that was submitted from a participant from Egypt? So I feel some responsibility to show it, because it's coming from my country. So can you show it? And I will try to. I discussed a little bit with Dr. Muhammad Mazyad, who gave us this case, his prospect. So maybe I can quickly tell you about the case, and we open the discussion for it, so we can save some time.
So, but if I may just say something sure. while you are changing, I think it's really very important to revisit this kind of techniques, because laminar foraminotomy is there for 80 years, so it's definitely not a new technique, but sure. It's really very powerful. And nowadays we are discussing more and more expensive things about new cages, expandable cages, cages with screws and other kind of things, that is increasing more and more the cost of surgeries. And on the other hand, this costs nothing except just an approach and the tube or a retractor or whatsoever, and it can be very effective in a lot of our patients. So I'm happy
this is a very
yeah.
important comment, Paulo. Actually, this is a very important comment. In the cervical spine specifically, we omitted all the implant-free techniques without a good reason. Is that right?
Exactly.
Yeah. Everything is looking for a procedure, especially in the cervical spine. We almost forget that there are some techniques that do not need implants. You're totally right.
Yeah, absolutely. Absolutely. And you have the tube, even if you don't use an endoscope, it's the same invasiveness. You have maybe 80 euros for the diamond burr, and that's it.
Yeah,
and
yeah, that's
if
right.
you use
That's
a cage and a plate and some bone substitute, it's much more expensive.
Yeah, that's right. That's right. Okay.
And you get implant-related complications also.
Dr. Zinger, can you repeat that? Your voice is going and it's cutting and coming back. I think this. Yeah, I know that you're in the train.
He's in the Deutsche Bahn. Bad connection.
Yeah, I know that. Yeah. Maybe he's not in the first class. That's why.
No, this is just Germany.
Don't talk politics.
And also you have the risk for the implant.
Now you represent Switzerland. Okay. That was very interesting discussion. Actually, this is very eye-opening. I think to the participants and for us as well. Imad, you will move the slides for me because I don't have the presentation with me. So can you move on? Okay. This is the history of this case that is presented by one of our senior staff in my department, actually in Ain Shams University, Dr. Mohammed Maziyad. This is 65 years male patient, diabetic, laborer, history of L45 neurosurgical microdiscectomy about 20 years ago. It was complicated then when the surgery was done by superficial wound infection, and it looks like it resolved in 3 weeks with oral antibiotics and wound debridement. He kept following up until 6 months after the first surgery, and he was doing fine. This was the technique. Next slide, please, Ahmed. Next slide. I want to show you what kind of surgery was done for this patient. It's okay. I think he came later. Can you go back, Ahmed? I'm just trying to remember what was the problem. Get back, please. Another slide. Okay. Okay. So he had some kind of instability 6 months after the first surgery. That was superficially infected. So the first surgery was just microdiscectomy with no implantation of any cages or screws or any implants. 6 months later, there was some instability, or I don't know, because it's not my case. For a reason, he had a redo surgery 6 months after the first surgery. And then now he had, because of his history of infection, he had this kind of fixation with antibiotics orally for 2 months after the surgery. And according to the surgeon, it worked well for 18 years. Get the next slide and then the slide afterwards to see what this surgery was. The next slide. Yes. So this is the surgery that was done 6 months after the microdiscectomy. This is fusion at L45 with a cage. And according to the surgeon, this decompression and fixation and fusion worked well for 18 years. Next slide, please. Okay, next slide. Okay, get 2 slides back because I think there is a new presentation of this patient 18 months after surgery, 18 years after surgery. Back, Ahmed. Okay. This is okay. Okay, so now the patient is complaining of back pain again, and I guess get back, Ahmed. I think there is weakness as well. No. Okay, so next slide, please, Ahmed. I'm sorry for this confusion, but we are missing the presenter himself. Now the patient is having severe back pain again. I don't see any clue here in this slide that there is anything neurological with the patient, but he is okay. Okay, so next slide. So these are the images of the case now with the patient having severe back pain, no weakness, and this is the CT images of the patient now with severe back pain. I don't see any clue here with the slides that there is weakness, and I don't see enough investigations if there is infection again or something like that. But there is, I think the main complaint now is debilitating back pain, and these are the images 18 years after the second surgery. Okay, can you get the next slide? I think these are only questions. Okay, these are the images. I think this is MRI, but I think this is one cut of the MRI. I don't see well the images here. And there are some images of the dorsal spine as well. I see just narrowing of a junctional level. I'm not sure which level is this. I think you can see it. You can see it here. Here, if this pointer is working, there is something in the dorsal spine here that I'm not sure because we don't have the next cuts. I don't think we have enough information to get proper discussion of this case, but at least get the next slide, Ahmed, because these are the questions that the surgeons are raising. Is this only a flat back with that needs only decompression of one level above and fixation, or do we need to work on the flat back itself and then get this flat back corrected? I'm sure that we don't have enough information to answer those questions, but let us make it like a brainstorming case. Dr. Bogus, what do you think about that?
Let's do, as you're saying, a brainstorming, because you're right, we don't have enough information from what he's suffering now. It's not clear. Even it is not clear when was reoperated, 18 months after 2004 or 18 years after, that means today. So for me, it's not clear why he done this surgery. I mean, he went for a fixation L4-5, and he remained that without seeing that there is an osteophyte in L5S1, as everyone can see very well. Also, he didn't kept the reason that said when we are doing a fixation, we should fixate above and lower, and also because the L4, L5 remains the L5S1 on the air. So
do you think,
me,
Dr. Gogos, sorry for interruption, do you think that flat back is a problem here or just adjacent segment degeneration?
Two things. Flat back, of course it is, but also L5S1 osteophyte that was wanted a drilling there, because as you can see...
I will tell you why I'm asking this question, because you all know, you are all very, very experienced surgeons, that flat back with a cage means that we will need to deal with this with something different than going through this level to try to remove the cage or do anything about that. So it might need an osteotomy of one of the vertebrae. What do you think?
No, I wouldn't remove the cage, because if the cage is already
So
in
you do agree
position,
that we will not use this space at all, but we have to do some osteotomy of one of the vertebrae, or work with the level below to correct the flat back?
exactly.
Okay. But you think
I
that
wouldn't
flat back is
extend.
part of the problem and adjacent segment degeneration is another part? Is there a chance that there is reactivation of the infection he had?
Well, reactivation of the infection after 20 almost years, I don't think so, because we don't have also results on this. And also, I don't agree for a fixation from L2 to S1. It's too damaged for the patient.
Okay. Dr. Zinger, are you having enough connection to give us your opinion?
Yeah, it's as you said, brainstorming, because without a clear assessment of the complaints, it's hard to guess. As Dr. Go said, it's quite invasive to do of L2 to S1, only to correct the flat back. So I don't think there's a reactivation of the infection. Otherwise, I think we would see some erosion in the CT scan of the screws or at the end plates. And I don't think there's any point for do a fusion at the moment, right?
So what do you think the solution for this flat back? What would you do if this patient is yours? I know we don't have enough information, but we're just brainstorming.
I mean, you can do chest infiltration of the facet joints. I don't know if he has a local problem there in the physical examination. You can do physiotherapy. Check again.
I think there is failure of conservative management. This is what I understand from the few slides we have. It seems like there's a real failure of conservative management. So if he's going to surgery, what kind of surgery you think this patient might get benefit of?
I think, if I may, because his connection, I think, is bad.
Yeah, sure. Go ahead.
I think if the flat back in the end, which we do not know yet, is the cause of all the problems, then you need a thorough workup and you need to plan a correction osteotomy, which is a very invasive procedure. If this patient,
so you think we need good standing films and see the spinopelvic parameters to see which kind of osteotomy can really work, and see which degree of correction we need, right?
Absolutely, just to see if there is any SVA deterioration. Also, it would be interesting to see old films from the past, if this has changed over the 18 years. And if he has done extensive conservative treatment, which also includes, in my opinion, injections, it would be nice to see the post-injection protocol if he has improved by any of those infiltrations, for example. And if he, by any chance, had a positive effect on 1 or 2 levels alone, then I would probably go with a local decompression there. If this does not help, you can also come with a big surgery.
Yeah.
I think all the things in between, like do a 1-level fusion or a 1-level or 2-level fusion there, I think this is not fish, not meat, you know? I think either very, very small, or you need to go very big.
It's very detrimental to determine with proper X-rays, standing X-rays, that if there is a positive sagittal balance. I do agree totally with that. It's going to be highly detrimental for what we really need for this patient. Dr. Paulo, what do you think? You're still with us? Paulo? I think Paulo is not here. Okay.
Professor Saud, if you allow
okay.
me.
Dr. Gogos, any further comment on that?
I want to add that I had a case 64 years old like this. Was treated first of all with a discectomy without adding nothing. She was continuing to complain for pain and like that. We proceed for a fixation the second time, L4, L5, S1. She continued to complain on that. We've done all the infiltrations that you can imagine, and still continuing with the VAS 10 out of 10, still now. And a professor from CAT, a bigger hospital in Athens, they asked her to put her a pump.
Mm-hmm.
To put her what?
This is 20,000.
A pump.
A pump, morphine pump. Okay.
Yes,
for opioids.
20,000 euros cost this one.
Wow.
20,000 euros. So,
and it did not help.
So the problems are everywhere. No, I don't know what she done till now. I will follow her if she gonna call me.
Okay.
Yeah.
Yeah, I think those cases they are critical because I mean he had this flat back like 10 years ago too. It has not suddenly popped up. And there was a good paper actually a year ago came out where you had like a severe lumbar lordosis pelvic incidence mismatch in patients who had a single level L4-5 fusion with a follow-up of 7 years, and even with a mismatch of over 20 degrees, this does not mean that they all have a pure outcome or revision surgeries all over. I think the compensation and the mobility of the spine and the Rossolini grades, they are very, very important. And you do not always have to come with a big surgery.
Yeah.
I agree.
Very good brainstorming. I think we have another 5 to 10 minutes. So, Ahmad, there is a last case that was sent by Dr. Sandeep Vaishya, who is one of our board members. I don't know why he didn't connect, but Sandeep Vaishya is known to have all his cases as private cases. So maybe there is a very well-paying patient that popped up. So he decided not to come to our meeting because he will lose a lot of money by being with us. Matt, can you show this? I know Sandeep. He might do something like that. Can you show us the case? I will also take the responsibility of trying to show you what's there. Maybe we can do some brainstorming with the information we have from this case. Okay, next slide, please. This is the history. It's 69 years old gentleman, resident in Iraq, known case to be type 2 diabetes mellitus, back pain following road traffic accident 2 years ago, underwent vertebroplasty for D12 fracture in Iraq. Now he's having progressive bilateral lower limb weakness following the vertebroplasty, re-evaluated in January of 2023 in a hospital in India, taking a second opinion, suspected to have tuberculosis of the dorsal 12 vertebra. Biopsy taken, suggestive of tuberculosis, actually. He underwent D10 to L1 pedicle screw fixation in Jan 2023 at a different hospital in India. So Sandeep is telling us that he's not the surgeon for the second surgery. Okay, we know Sandeep. Started on an anti-tuberculous therapy, discontinued 3 to 4 months later by himself without consulting the physicians. Then he presented recently to the center where Sandeep is the head of spine surgery there, with progressive worsening bilateral lower limb weakness, unable to walk without support, associated urinary urgency and constipation. Next slide, please, Ahmad. This is the examination. There is nothing wrong with the upper limbs and the shoulder girdles. Hand grip is okay. Hip flexion and extension are slightly affected. knee flexion and extension are okay. And then the ankle dorsiflexion and plantar flexion are affected, but they are not zero. They're from 3 to 4 grades. Now for the this is the so the plantar flexion is affected bilaterally. There is some sensory affection on the L4-5 distribution on the left side. Next slide, please. Few images of this patient. This is the on the left side. I'm not sure if this is standing X-ray or not, but it showed the vertebroplasty and the fixation up and down. And this is an MRI with some distraction of the electromagnetic field, definitely because of the implants. Can we see the next slide to see if there is more? Okay, I think this is a clearer image of MRI cuts, where there is obviously some compression posteriorly with loss of the vertebral height and some kyphosis at this level, localized kyphosis, as I see it here. There is some canal stenosis here. This is from the images we see here. Next slide, please. So the questions to the board: would we remove the implants? How to deal with this dorsal 11 and dorsal 12? Can we see compression? He sees this as an infection. We would discuss if this is a clear infection or not, and would decompression helps. So get back, Ahmed, to the image before that, and we can start the discussion from here. Dr. Gogos.
Well, it's very unhappy and very unpleased case. I will go directly to the third questions. First of all, for me, the vertebroplasty is not good. Secondly, the screws, they must be removed, all of them. And third thing, the laminectomy, maybe with the way that we described before, would be an option. So everything went wrong for this case for me. And my answer to these three questions is that. Screws
Benedict?
removed.
Yeah, I think. Well, I think that the vertebroplasty in the one slide, it looks a bit. It looks for me that the upper end plate of the vertebral body with the vertebroplasty has been separated from the vertebral body itself, and the the segment above probably is infected, and the disc is gone, and there is some instability. Maybe the screws are loosened. And I think the problem with the neurological deficit is due to instability and due to infection. And so if you go there in with the surgery, you have to probably remove the screws, extend the construct, and then get anterior support. Because if the vertebral body is gone and there is instability in the vertebral body below and the disc is gone, it's difficult to stabilize this all from the back.
Can I just ask a question? I don't have the answer, but for Dr. Gogos and Dr. Benedict, we don't have enough information if this patient was subjected to any kind of, because he's proven to be tuberculous. Did he take anti-tuberculous again? Is there any response for that? Do you think there is room, because it's not complete neurology, for some conservative management first before we go to decompression? What do you both think?
Yeah, I think that the diagnosis of the infection and the specimen has to be absolutely clear, because surgery without the medical treatment is useless. So he has to, I mean, this has to be done, no matter if he gets surgery or not. But on
So
the
if you are
MRI,
going to do this, are you going to do this again before deciding for surgery? And if it is proven, you would go for conservative management first, or you think that this is should be complementary to surgery?
I think first we should do the medical treatment till the patient is in a stable situation. However, if the patient deteriorates with the sensomotory symptoms, then you have to do the surgery earlier. And when I look at this MRI here in the upper row, for me, from the right side, it looks like there is like a mess compressing the thoracolumbar junction and the conus cauda.
And
On
after
the right side,
after decompression, what are you going to approach this from posterolateral or what? The decompression.
I would do the decompression from posterior, check the
Posterior, okay.
integrity
So
of
it's
the
a
implants and the
posterolateral
stability.
thing.
And when there is a good stability from the back and the decompression is done, then I would check with the standing X-ray how the patient, and also look how the patient is doing. And if I think that the construct is not holding the posture, or that the biomechanics are poor, then I think from posterolateral you cannot remove in my hands, it's difficult to remove the vertebroplasty of the vertebral body here thoroughly. I think this is better be done with a lateral approach.
Okay, so you think you're
I
going
think
to
the
do
vertebroplasty
a
has
kind
to,
of posterior decompression, but you're not going to be able to decompress the anterior aspect of the compression from posterior. Do you think so?
Yeah, I think the decompression of the anterior lesion from posterior with the bony cement already in is challenging.
So any idea that you can go for this anteriorly from the beginning?
Do everything from anterior?
Do removal of the vertebra, use an expandable cage or something like that. Do you think this is feasible?
This is reasonable once we are sure that the screws are have a good integrity and they will hold it.
Dr.
If the
Gogos,
screws are
what do you think?
loose,
Dr. Benedict is reading my
Dr.
thoughts.
Gogos, what he thinks by going to anteriorly?
I agree totally with Dr. Benedict. I would say that the screws are loosening. Also, we can see it from the scans. Only from the back, the vertebroplasty we cannot touch unless if we are doing only the laminectomy good, so we can breathe from the back side. We cannot remove it, because if we have to remove it, we have to remove it only with one way, to do corpectomy. And if we do corpectomy, we have to fixate in other ways. So the less, the best. Remove the screws that they are doing the problem of the pain. The vertebroplasty cannot be touched in that way, and combined after we remove the implants, start combined even before the surgery, or 1 day or 2 days or after, for 3 or 4 months for the antituberculous treatment. Not anteriorly. Not anteriorly.
Yeah. The thing here, Dr. Gogos, I think that's a reasonable point of view from Dr. Benedict, is that there is part of the compression that's clearly coming from the body of the vertebra that have cement injected in. So whatever we do, we cannot remove this part of compression. So by only doing implant removal and decompression from posterior, there is still an element of compression that might make the neurological recovery not complete. What do you think about that?
Exactly. I agree.
Yeah.
I totally agree.
Yeah. But the point is, the compression from anterior, do you think that this is a solid mass, like bone alone, or do you think that this is infection and the instability of the segment contributes to the symptoms?
I think it's both. It's both.
Yeah, I think it's both too, but I don't think that it is bone alone.
Yes, sure. Huh? It's partly what I'm talking about, and I think
the imaging
this
is with
point of view is that it's partially coming from the compression is all around, but it is also a dynamic compression rather than static one. So there is a problem
and that's why I think,
and you're right.
And that's why I think
going anterior is going to give you another option. Full decompression is possible.
I think first we need to get
put the cage
stability
from the front or graft, and also you can resort to anterior fixation. You can put a plate on the lateral aspect of the vertebrae, and you can add to stability from this side.
Yeah. So I totally agree with you. I would first go from the back and see how the outcome is, and if it's not successful, you can still add on.
Actually, for myself, I would go to the front from the beginning, do decompression, because I can do full decompression from anterior aspect, as you said, and I can also put an expandable cage. It's going to be depending on what is the status of the end plate. Is it strong enough or not? I can judge this intraoperatively. If it is strong enough, I can put an expandable cage after full decompression here and add a plate. If it is not a good end plate, I can just put, actually, I use fibular grafts for this. I can put a couple of fibular grafts and put a plate from the anterior aspect, and I would, then I dealt with both the problems, the instability and the compression. This is my own point of view. I'm not sure if it is the same opinion that you might share with me.
Yeah. No, you're right. But you have to, I think in this case, you have to remove 2 vertebral bodies.
Exactly. But I think
because the one vertebral body, the lower end plate is almost gone.
No, you're right. You need to remove 2 vertebral bodies. That's right.
The vertebroplasty, I would not leave the vertebroplasty with the cement in the infection site.
Yeah.
So
it's a big deal, right? It is a big deal. Yeah, there is no easy solution for this patient.
Absolutely not.
Yeah. So we can stage the procedure according to Dr. Gogos and Dr. Benedict. We can go from the posterior aspect, do decompression, replace the screws, or go to more levels above and below for more stability. And if the patient improves like that with an umbrella of antituberculous management, it's fine. And then leave the anterior aspect of the surgery to if the patient is not doing well. Another way of doing that is to do this completely from the anterior aspect, gives better decompression, one-shot solution. But the problem is that we are going to remove 2 vertebral bodies that leaves a wide area in need of grafting or expandable cage, with suspicion that the end plates, even in the levels above and below, would be strong enough to hold this expandable cage. And we can add a plate from the lateral aspect of the vertebra, screws and rods, or a plate, or any kind of lateral fixation that we call anterior fixation, but it's actually lateral fixation of the vertebral bodies to this solution. Is Dr. Zinger having enough connection to comment on this one, or still the German train is giving you a problem, according to Dr.
Thank you, Professor. So I was able to follow the discussion. So
okay.
I agree with you to offer the patient a definite solution. So I would also aim for a anterior vertebral body replacement. But of course, as Benedict said, you have to remove the vertebroplasty in the infectious side.
And you agree that if you need to remove this cement, the only way is going anterior, right?
I would recommend going from lateral, anterior, lateral,
Yeah. Very good. Okay, that was a very nice brainstorming case. Dr. Paulo, are you still here with us, or no? I think I see something in the chat. Is there any other question from the participants? Left side screws, lower just pass. Dr. Iyaz, are you still with us? If you want to comment on this case, the first presenter. And also Dr. Alejandro Martinez. Dr. Iyaz, do you have a comment on the management we discussed for this case? Dr. Alejandro Martinez. So I will tell you what Dr. Iyaz is saying. Left-sided screw lowered just past. Dr. Iyaz thinks that, I think he's having the same opinion with Dr. Gogos, that one of the screws is the problem. It's in the canal, but I think these screws have been there for a long period of time. Maybe it moved with the infection, maybe. So it could be part of the problem. So you still think that, as Dr. Gogos said, that the removal of screw is detrimental. Fine. Dr. Alejandro Martinez, reduction for the patient for the list to the first treatment of tuberculosis. Okay, he thinks that the deformity that's caused by the infection is part of the problem, and we talked about this already. Okay, so this was very interesting. We are. I'm sorry that the time passed that quickly. I have to thank the great experts that we have with us today. Dr. Christos Gogos from Greece, Dr. Sebastian Zinger from Germany, Dr. Benedict Burkhardt from both Germany and Switzerland. So he's a player of two national teams now. And we had, I think, very fruitful discussions, although in two of the cases we had very few information, but we used the cases for brainstorming. And I think the four of us and the great participants we had made very clear that there are a lot of messages to be taken home, and I think that was very useful. Thank you very much for the experts we had. We had a lot of your time, and we know that you're very busy, and it was a great opportunity to meet all of you as friends and great surgeons and experts, and we really enjoyed exchanging experience with the three of you. Thank you so much for your precious time, and we hope to meet you in person or online in the very near future. Thank you very much, Doctor. Thank you
for having me. Thank you.
Thank you.
All the best. Bye-bye.
Thank you.
Thank you, Dr. Gogos.
Thank you so much.
Thank you for the
pleasure.
Yeah, thank you very much. Thank you for the participants. We had almost 50 participants today, which is a very good number. I hope you all enjoyed the discussions and the brainstorming. It was a real eye-opener. Thank you, Dr. Paulo, for being with us. Thanks for the technical support from Mr. Ahmed from Pakistan and Mrs. Shana Imler from Cleveland. Sorry for the 15 minutes delay, and we promise you next webinar it won't happen again. Thank you very much, friends. See you all soon. Bye-bye.
All the best. Bye-bye.